such a pleasure to be here. Thank you so much for the invitation, Christina, Andrew, and Alison. I'm so grateful to have this opportunity to speak with you in many ways about my professional journey over the last 20 years or 25 years or so. It's not often you have a chance to reflect. It's a gift. You know, we're so busy working, moving forward. It's not often you have a chance to reflect and really distill a few lessons learned along the way. So when when Christina approached me for this talk a few months ago, I've spent some time thinking about what are the lessons I've learned along the way that are worth sharing to a body like yours. And so I focused on co-production and the lessons I've learned along the way, some of them really tough lessons, which in hindsight I should have known, other lessons I couldn't have predicted. So I labeled my talk The School of Hard Knocks and Co-Production. I have nothing to disclose. The session objectives should be in your packages, but I'll just quickly refresh your memory. It's about gaining insights into the centrality of curiosity in how we do our work in listening and learning. It's also about ensuring that we don't have blind spots, recognizing the common pitfalls that may come along the way and how we can avoid them. So I want to start with a story. This is about 17 years ago. I had just started my journey as an improvement advisor, just joined IHI. I was coming from a background in medicine and public health. I'd worked in community health, but I did not know improvement science. And IHI spent a year investing in me, learning the knowledge and skills of improvement science. And I had to learn it and practice it at the same time, almost like, what's the word? Drinking from a fire hose, that phrase. So I was actively learning and practicing, and we were working on a large-scale quality improvement initiative in Ghana to reduce mortality in children under age 5. And we were working with clinics and hospitals all over the country. And this was one of the clinics that I visited with a small team. I had an improvement advisor with me who was more seasoned, more experienced, and I had a junior staff member with me as well. And we visited this clinic, and we had spent, at this point, we spent probably like 30 minutes, 40 minutes trying to understand what are their priorities, what are the opportunities for improvement. We'd gone round and round trying to engage them. There was a midwife, the lead clinician in this clinic was called Stella the midwife, and with her team of maybe 4 or 5 people, and we're trying to engage them in co-production, really. We were trying to figure out how can we be of help to them as improvement advisors. And after several minutes of trying back and forth, we're getting nowhere. I mean, we were almost, stonewalled in many ways. So I looked across to my colleague, Kathy Green, who was the seasoned improvement advisor, and I looked across at her. I couldn't speak with her because she was across the room, and I was trying to read her body language as to what we do next. And so I have a question for you all. What would you do in this situation? I'd like you guys to spend maybe a couple of minutes talking with each other. What would you do when you're faced with a situation where you are trying to be helpful, you're trying to co-produce, but you're facing disengagement, resistance, whatever you want to call it. So, time is now. Thank you so much. So, I want to see by show of hands which tables chose option A. Pull out your root cause analysis template and try to facilitate the discussion. Option A. I see a few tables, okay, handful, fewer than 5. How about option B? Report the midwife to her supervisor for non-compliance. Anybody? No. I don't see any. Okay, great, excellent. What about C? Get some food and drinks, try and warm up yes, okay, about maybe a third of the room thinks food and drinks can do the trick. And then which group thinks wrap up the meeting and re-strategize before returning another day? Smaller. Oh, okay, all right. Well, I'm gonna do the big reveal now. The big reveal, Kathy Green, you see on the screen, my seasoned improvement advisor and coach at the time, her body language to me was like, let's just call it a day. And later on when we're returning to our offices, the debrief that she had for me was thinking about the work of improvement advising, improvement coaching as co-production. And with co-production, if the other party isn't ready to engage, you can't do anything. It's a two-way street. You cannot tell, you cannot kind of mandate. So anyway, that's how I started my journey as an improvement advisor, and I thought it was worth sharing that. So for this talk, I'm going to emphasize 3 main lessons that I've learned. The first is around curiosity, which I mentioned in the session objectives. The other one is around learning without action being a form of waste. In addition, action without learning is also a form of waste, right? Because we lose the opportunity to do what matters to the people that we're working with in co-production. And then finally, not everything that matters can be measured. And before I get into the substance of the talk, I wanted to share a little bit about myself. I was born and raised in Ghana up to my early teens, and then my family moved to the UK. And I've worked in West Africa, East Africa. I've worked across the world, as you see. The gray positions are where I've worked, the yellow is where I've lived. So I see myself as a global citizen, and I think having this opportunity to live and work across different cultures, countries, economic settings, and languages has really helped me become a better person in so many ways, including professionally, and that's what I'm gonna share today. So with curiosity being at the core of active listening and learning, I learned that from this gentleman that many of you will know, the founder of IHI and currently President Emeritus. He's on our board. And Don Berwick visited the large-scale quality improvement work that I was working on in Ghana. And he was very curious, as he always is, but he also taught me the importance of my own nurturing of curiosity. Even though I'm from Ghana, I'm from a particular part of Ghana. It's a big country, more than 30 million people. So I had to stay curious as I was learning about the things that matter to the people, the nurses, the doctors that we're working with, and how we could be most helpful to them. And then from Maureen Bisognano, the former president of IHI, second CEO, I learned a concept called curiosity quotient. All of us in this room would have heard about IQ, intelligence quotient, and increasingly, more and more of us know the importance of emotional quotient, meaning the socio-emotional skills it takes to manage our emotions in situations, be more tolerant of people. So that's the emotional part. This curiosity quotient I hadn't been as familiar with until Maureen introduced me to it, and in many ways helped me practice my curiosity skills more. It's about being open to ambiguity and being comfortable in that space. A few years ago, 2 years ago, I was encouraged to do something like this, like what Christina invited me to do, think about my journey as a leader, what have I learned, what is it worth sharing with people. And over time, as I developed my thinking, I kind of put it into something I call a listening arc. And at the beginning of that arc comes curiosity. Without curiosity, there can be no learning. That I've been practicing for more than a decade or so. And then as you learn what matters, there's opportunities to align without too much friction. When there's no opportunity to align, oftentimes we can negotiate, we can find common ground if we're truly listening and trying to move forward in co-production with patients or families or communities. And then finally, if there's no real middle ground, perhaps we could think of something new. We can do some blue sky thinking and come up with an idea that neither party had thought about before. So I put that in a paper that was published just last fall. You can look it up, the references there. And in that paper, I really emphasized the importance of empathy, leading with empathy, the importance of humility, really appreciating what we know and what we don't know, and being conscious of the fact that organizations are complex, constantly evolving, and may evolve in ways that we can't predict. So we need to be open to that. And you can read more about it in the article. And importantly, over the years, as I've thought about how I can improve my curiosity skills so that I can be a better learner and a better improver, I've picked up a few of these that I think many of you will recognize. I understand yesterday after lunch, there was a very vibrant debate where people had to pick a side, and some people picked this or had to argue a side that they didn't necessarily believe in because they was assigned randomly, which I think is great. It's really good for us as human beings to put ourselves in the shoes of other people and really try and debate things from their perspective. Almost all of us in healthcare and public health work with other people from other disciplines. You know, I'm trained as a physician, as a public health person, and there's a lens through which I've been trained for so many years, and therefore sometimes when I'm interacting with other professionals, I might not understand the perspective they're coming from. When people use their epistemologic framework that's different from what I'm coming with, I need to be humble and ask and learn and try and put myself in their shoes. So that has really helped me think about how to continuously nurture my curiosity skills. In healthcare, we all learn about motivational interviewing as a way to generate intrinsic motivation in patients and families, learn more about them, give them a sense of agency. And I think I saw that several of the, one of the storyboards was about what matters to you. And I think being healthcare providers in North America, you've been practicing the What Matters to You movement. You're part of the movement, I know. And many of you will know Jennifer Rogers, who's a pediatric nurse from Scotland, Glasgow, Scotland, who really has been a driving force of the transition for us healthcare workers, focusing on our technical skills, our clinical diagnoses, our treatments, going from that to putting ourselves in the shoes to what matters to the patients and families. And the What Matters to You movement has really grown across the world and still growing. I think it's been such a big driving force for the work we do at IHI, has been over the last decade and a half or so. One of the things that, as I reflect on my own journey, sort of the distinction between what we produce as goods, you know, widgets or, you know, devices, versus what we do as healthcare workers in community, in clinics, in hospitals, thinking about the importance of reflecting to learn and make sure that we are truly co-producing as opposed to telling, prescribing only. So I'd like to take you back to my experience with a midwife in Northern Ghana, Stella. So as I reflected with my colleague Kathy Green when we left Stella's clinic, one of the things we realized was that being a midwife in a rural clinic, she lived on site, and therefore by default she was providing 24/7 services because the community members could knock on her door, could come to the clinic at any time. She barely had enough time off because the service at the time was understaffed. She was living away from her family, so she needed to find time to go home at least once a month, spend some time at home. Her supervisor rarely visited, and at the time, the health service in Ghana was really using data for judgment. There was a culture of using data for judgment rather than improvement. So this is the context in which we were meeting her. And of course, we had some of this in our background, but in the backs of our heads, but we didn't fully appreciate it until we were in a situation where we faced the resistance and the pushback. And so thinking about what would it take to overcome this barrier with Stella to get her open to thinking about the priorities in her clinic and perhaps engage in an improvement journey with us. So let's continue the lessons. So lesson number 2 for me was learning without action is waste. Action without learning is also waste. Deming, one of the pioneers of improvement science, emphasizes this, the importance of the knowledge in the systems in which we work, the people at the front lines, the people in middle management, their knowledge of the systems, their desire to contribute to improving the systems, if only we would ask, or if only we would not just ask, but do something with the things that we learn from them. The IHI has focused on this aspect of the people at the front line, the people in the system, in the middle management, really know what could improve their systems. We have a framework called the psychology of change, which really emphasizes unleashing intrinsic motivation, harnessing the wisdom of the people in your system who are the process owners. This is what Deming calls the people who are closest to the process, know actually every day, they see the failures in the process and they know how to improve it. So tap into that wisdom. How do you design with them? How do you co-produce with them? And make them feel a part of the system. They're not just widgets in the system, but they're part of the system to improve the system overall. And what I've learned from, this also came from Maureen, IHI's former president, was around the importance of listening on multiple levels in order to go from hearing people's frustrations and thinking that they're complaining. So oftentimes as leaders and managers, we get a lot of the negative feedback. We don't always hear when things are going well, but we hear things are not going well. And it's easy for us to get on the defensive, right? It's easy not to hear the pearls of wisdom that are coming through the frustration. So how do we teach ourselves deep listening is what this slide is about. So the way I've used this slide in my own practice is thinking about situations where you anticipate what the person's gonna say, you predict, you know them well enough, you've been down this rodeo with them many times, so you're kind of nodding as they speak. So you're not even listening to the full sentence or the full thing they're trying to say, you nod. That's listening level 1. Listening level 2 is what I would consider, you're listening and then you become a bit quizzical and you kind of, you're like, oh, that's interesting. Meaning that you're genuinely listening. You're not predicting you can't predict what they're gonna say because you're in uncharted territory. This is where the curiosity quotient comes in, being open and tolerant of ambiguity. That's level 2. And then level 3 is not just being quizzical and curious, but actually leaning in and being empathetic, really trying to understand where they're coming from, putting yourself in the shoes of the person you're engaged in co-production with. And then level 4 is not only being empathetic, but partnering with them to be part of the solution, to help solve the problem that they're coming to you with. And I think that's where a lot of this comes from. So on the next slide, I'm gonna ask you to go back into a brief discussion at your roundtables to share any tips and tricks that you use to help improve your listening skills. I can share a couple. I'll give you my own. I have two tricks that I use. Those of you who might know me well, I'm an extrovert and I tend to talk a lot. So you know that listening is really hard for people who talk a lot. I have 100 things to say every single day. I wake up and my brain is fired and I'm ready to go. So people like me really struggle with listening. I've had to work on it my whole life. And so I'll tell you 2 of my tricks. And if you see this, you know that I'm working. So I usually put my hands under my thighs when I'm sitting and sit on my hands and keep my hands there to force myself to listen. It's kind of a trick. The other thing that I do is I kind of put the energy that I want to use to speak, I put it in my finger pads, put my fingers together and push really hard to remind myself to listen. And as I do that, I'm also leaning in. And as you lean in when you're talking with people, they tend to give you more. Leaning in invites them to share a little bit more. Being quiet for a lot longer than you're speaking also invites them to share more with you so you can truly learn what's going on with them. So for you all, over the next couple of minutes, can you reflect what are the tips and tricks you use to improve your listening skills? All right. I wish we were in smaller groups so that we could share some of our tips and tricks with each other. But I encourage you during the lunch break to find each other and explore what new skills, new ways you can use to remind yourself to speak less, listen more. All right, so I want to share a few examples of what matters to you, the use of what matters to you in parts of the world where IHI has been working. This is in Brazil, Sao Paulo. Syrio-Lebanese is a hospital. They're one of the most prominent hospitals in Brazil. And they've used this simple what matters to you engagement to improve their staff engagement, staff sense of agency. You see a board on the right where the staff post what matters to them, what they think can be done to improve their system. And most of the things were cost neutral. It's just ideas about from people close to the front lines. And then they theme the ideas that come up on the stickies, and then they task working groups to work on them for a certain amount of time, and they come and they improve, they work on improving their system. And this is one of the metrics that they use to assess their progress, which is staff's reporting or feeling that they're engaged in improving the work of the system. And they went from about 40% to 70% in a very short time, and were able to sustain that. You'll see the picture on the left, the lady in white. Her name is Vania Bahia. Is the team leader who started this effort. She wasn't sure it would work. She was afraid that people are going to come with all kinds of ideas that the management wouldn't be able to support, that would end up being costly. And instead, it really brought out the best in her team, and retention levels improved, et cetera, et cetera. The next one is from Australia, is the Victoria Worker Wellbeing Initiative. It was a 3-year initiative, I think, from middle of 2021 to the middle of last year. And here there were 36 different health services participating in this initiative. 100% of the teams engaged in the What Matters to You conversations, and they were able to measure staff well-being, tested all kinds of interventions to improve the working conditions for their staff, and 93% of the staff did report feeling more joy in work as a result of this initiative. And again, here's one of the graphs from their work. On the x-axis, you have joy in work. On the y-axis, you have burnout. And you see that as joy in work, as they are reported, joy in work increases over time, burnout rates decrease. And this has been really powerful for us. And the framework that we've developed over time to guide these conversations, to make things a bit more structured, to make things a bit more scalable, is the Joy in Work framework, which has 9 components, including participatory management, which is at the bottom, recognition, rewards, teamwork, camaraderie. You see the details in the flywheel. So the Joy in Work framework has been really foundational to how we think about co-production with patients, with staff, as well as with communities. With communities, there are lots of other methods we can use. Some of these, I'm sure many of you have used these methods around participatory research, focus group discussions, participatory and action research. People call it a lot of different things, but it's essentially learning from communities. And then the question is, what do we do with the learning? How do we harness all that wisdom about the needs of the communities into something that's meaningful, that does make their lives better? And as we do that, we need to be conscious of the risks of what we call white elephants. Who's heard the term white elephants? A few. Okay. Maybe 20%. Okay, so white elephants are basically oftentimes projects, things that are built, developed with good intentions, usually the best intentions, to meet a need, but doesn't always address the need. Oftentimes because we did not learn enough about what matters to the people, or we didn't learn enough about their context to know exactly how to shape the intervention to be most relevant. So in the middle, you see an ultrasound machine. And this is a typical example. In fact, medical equipment is one of the areas where you find white elephants often in development, where people with good intentions donate medical equipment to countries far away, and either the machine arrives and the people don't know how to use it, or even in this case, it's as simple as a transformer. This was a 110 volt device that was being shipped to a country with 220 volts. And the people in the rural area didn't have access to a transformer, because transformers aren't that common if you think about it. You have to be kind of in a capital city or a big city where people are used to importing products from other countries. So this ultrasound machine sat unused for more than a year because they couldn't get a transformer. When they finally got a transformer to get it to work, people needed to be trained. The midwife was not used to the machine, so she didn't use it as often as was expected. And then importantly, the Achilles heel of a lot of medical donation programs is repairs and maintenance. The people far away from the cities don't have the supplies, they don't have the knowledge on how to maintain this equipment. So then it ends up being essentially a white elephant. On the top right, this is an experience I had in India many years ago where I was working as an improvement advisor with several hospitals in India. And I remember we're having what matters to you conversation type things with the nurses. And the nurses were saying how frustrated they were because the gloves in their hospital were always too big for them. And in this part of the country, the women were small, they were petite, both in terms of height as well as width. So the medium-sized gloves that were the standard issue for the hospital were just too big for them. And they had complained that it wasn't safe, infection prevention and control wasn't working because they couldn't keep their gloves on during procedures, but they weren't being listened to. And so things like that, this is where empathy comes in. This is where, learning from the people and then acting for the people, not acting based on some kind of standard protocol that may not be relevant in that context. And as you can imagine, with IHI, we've been thinking about this a lot. We've in the last few years, we've sort of codified what we think will help improvement projects be more likely to succeed. And we call it the 6 components, which, as you'll see, starts at the beginning with system understanding. System understanding requires contextual knowledge, asking questions, pouring through data to understand what the opportunities are for improvement, and learning from that to design the project and using the 6 core components while you're delivering the project as well as when you're wrapping up and disseminating and scaling up. And importantly, making sure that you have a learning system within the project from the beginning to the end, both summative evaluation as well as formative evaluation. And this has helped us when we provide services to institutions who want to partner with us on what's the best way to design an improvement project. In addition, for ourselves as improvement advisors, when we are supporting institutions, how do we do this? How do we stay disciplined on the learning system, making sure there is a learning system, has the right amount of data, has the right type of data, and that we're using it for learning and adaptation, not just summative evaluation at the end. Okay, I've said a lot. Let me go back to Stella for a second. So the last time I talked about Stella, I mentioned the fact that the system in which she worked, there was a culture of using data for judgment, not for improvement. In addition, what we learned was that, and many of you who've been clinicians know this, data without being set up for your use or used in a way that you can see feels like an administrative burden. It feels like you're just reporting up a whole bunch of data. You don't know what happens to the data. Nobody gives you feedback. And in this particular case, this was 17 years ago, most of the data in the Ghana health system was paper-based. And the midwives and doctors were sending their reports on a piece of paper monthly, basically a snapshot of their work every month without opportunity for longitudinal analysis. So trying to talk to Stella about how are things doing? What are the areas for improvement? What's your performance been over the last 6 months? What's the performance of this particular metric over the last 12 months? She couldn't actually answer those questions because she wasn't looking at her data longitudinally. She was looking at her data in snapshots. And with snapshot data, what happens usually when you ask people about what are the opportunities for improvement, there's usually recency bias. They're going to tell you something that something they noticed last month or the previous month. But as we know, with improvement, you do need to look at data over time. Sometimes there's noise. There might be months where something goes up or goes down, might not be relevant. So looking at data over time was not an opportunity she had with her own data. And therefore, as improvement advisors and coaches trying to help her, she didn't have the data. We couldn't have a data-driven conversation about her priorities and how we could help her. So that was important learning for us. Okay, and then the third lesson, I have to share is that not everything that matters can be measured, at least not precisely. And I know yesterday we had a really nice talk from Chris in the morning about trust. I'm going to get to trust a little bit in this session. Let's first talk about kindness, though. Kindness is something that we know when we experience it. Unkindness, we also know when we experience it. It's sometimes hard to describe. So I'll just tell you a story about a moment in my life when I experienced kindness from a stranger that really moved me, has stuck with me many years later. I was a young doctor on call, and I'd been up a couple of times during the nights. I think the nurses had called me because a patient was declining, or somebody needed different medication or something like that. And so I'd been up a couple of times during the night, and then I showed up at 6 a.m. to do my rounds before my senior doctors arrived. And an elderly patient who'd been there for about 2 or 3 days said to me when I got to her bed, she said, "You look tired." And my instinct as a doctor, as a young doctor who was trying to prove herself, this was probably her first year, was to say, "Oh no, I'm all right," just kind of, put my shoulders back and pretend I was all right. But I saw something in her eyes, and I'm not sure what it was. She was about the age of my grandmother, so maybe that connection helped me. But I was honest. And I said, "Yeah, I'm tired." And she held my hand and she squeezed it really tightly, as if she saw me, she heard me. And it moved me so much because there I was as a doctor, supposed to be healing her, supposed to be providing her comfort, and there she was providing me comfort. And so I think, and how do I measure this? How do I measure it? How do I replicate it? How do I teach it? It's not that easy. But as human beings, given the theme of this conference, we know human connection when we see it. We know when people are being kind to us. We know when people are going out of their way to see us as human beings and respond to us in a way that is meaningful to us in that moment. And I just wanted to say that as improvers, we love data, we love to derive insights from data, but sometimes it's the qualitative that we need to search for. Here's another example. This is from my work in northern Ghana. And this midwife you see on the right, her name is Hajia Mary Issaka. And she was a national treasure. She was already, by the time I met her, she was already in the newspapers for having shown empathy, having shown, being one of the best practices that other clinics were being encouraged to adopt. Basically, when she was a relatively new midwife, she had been posted to a rural area where there was a great need for her services. But she noticed that the community wasn't using her services. The pregnant women weren't coming in for labor and delivery. So she went to talk to them to find out why not. And they told her that the staff at the clinic don't show respect, don't treat them with dignity. And importantly, there was something that was missing in what they thought was really important, which is this millet drink. You see a picture of it. In that community, they believed that that particular drink was really helpful after childbirth because it improved lactation. And so she said, "Okay, that's fine. I can make this millet drink available. It doesn't change my clinical practice, doesn't upset any of my protocols. So we'll make sure there's hot water for bathing because in the mornings it's very cold. At some times of the year, the mornings are really cold. So the women wanted hot water for bathing rather than cold. They wanted the millet drink. And they wanted to be treated with respect. And she did all of that. And the community started using the services. So simple, unique, context specific. She had to go, she had to listen. She had to be in co-production with them. She had to see them as human beings. As a midwife who had been scientifically trained, she probably didn't believe in the power of this millet drink to make a difference. But because it made sense to the community member, she was willing to do it for them so that they would use her services. And trust is another important one that is very hard to measure. I'm looking at Chris and the House of Trust. You see, it's one of those things you know it when you have it. You also know it when you don't trust institutions, when you don't trust providers. This is a story of a health transportation initiative that I started a few years ago, where based on what made sense, we had talked to the communities, we had found out what they needed, we provided the tricycle vehicles close to the communities where they could access it. And we also introduced a toll-free number that they could call at any time. So we would then find which driver was most available, who was closest to them, and get them the care they needed. What we learned after 6 to 12 months was that our toll-free number that we're paying a lot of money for was barely used, but the drivers were getting phone calls directly from the community members, and people were running to knock on their doors. People were using bicycles to get to the drivers. And what we learned from the communities when we asked them, why don't you call the toll-free number? Maybe you could get a tricycle more quickly. They're like, well, the toll-free number, it's a stranger on the phone. We don't know who that person is. We feel more comfortable activating the driver that we know by name. We know his family. We've known him his whole life. And so it taught us something that, sometimes you do your best research, community needs assessments, participatory research. You learn what you can. You put in place what you thought you learned that will make a difference, and sometimes it doesn't work. So you have to learn, you have to adapt, and try again, and maybe this time we'll respond. The other thing I wanted to talk about is the power of rituals. All societies, I told you I've lived in like however many countries and worked in however many, and I've seen so many different rituals and that are really important to people in a particular context. So rituals around birth, rituals around death. In some communities, cremation is what is normal, expected. Other places, we bury our dead. Some places have something called a wake keeping, where the corpse or the person that you're saying goodbye to is with you for 12 hours or more in the home before they're actually buried. And all those things have meaning. Can we measure them? Can we say that if we don't have the evidence on how they influence people's behaviors, can we say that one thing is better than the other? And I think, again, it goes back to the human connection, having respect, having empathy for what is really important to people. I'm getting to the end of my talk now, and so I'm coming back to healthcare, the things that we know in healthcare. Many of you would have heard of Gemba Walk, going to the front lines, going to where the work takes place, to see for yourself, to learn for yourself, things that may not be in the data, things that might not yet be measured or be measurable. So going to an emergency department like you see on the left, which is crowded, the patients in the hallway, and the providers telling you how stressed they are, how overwhelmed they are, how they feel like they're on a treadmill, they're never catching up. Hearing that in a meeting room or a conference room far away is very different from going into the emergency department and seeing for yourself and feeling some of the anxiety, feeling some of the overwhelm yourself, and then going back and saying, wow, what can I do differently? What are the resources or what are the changes? What are the redesign opportunities we have to improve that emergency department operations so that our staff don't feel so overwhelmed, our staff can make progress and feel the progress, and patients can get the good care they need. Same thing with the picture on the right, which is a community. You can see houses very close to a highway. And this could be the family with a child with asthma who comes in regularly with asthma attacks. And you're trying to understand why does this 8-year-old keep coming in with asthma attacks? And they're using their medicines. And is the family non-adherent to the medicines? And you go to their home and you see how close they live to the highway with all the air pollution. During the warm months, they can't even open their windows because the air pollution is so strong. And then you have empathy, and then you figure out how can you help them. So making sure that we are going and seeing with our eyes, hearing, feeling, touching, using all our 5 senses to learn before we make firm conclusions. And of course, many of us will know the diffusion of innovations curve, where we really, many of us have been taught to explore the best practices, see what's already working, and not necessarily come up with new things. Many systems already have really good best practices. What can we learn from those best practices and accelerate the spread and adoption of them? I think that's really important. I've done it myself. In fact, the midwife I mentioned, Hajia Mary Issaka, was one of those innovators, best practice that we're learning from to help spread it across the country. We also have to explore the laggards, the people who are well behind the curve, who are not interested, who are disengaged. People like Stella, people like the midwife I met at the beginning, I introduced at the beginning. people like Stella, what can we learn from her? What are the contextual issues that are relevant to Stella that we may not be aware of that might be influencing the work and maybe give us new ideas for what we could do differently. And as we talk to the outliers, the laggards, we may actually be able to generate new hypotheses, things that we haven't thought about before. And maybe with those new hypotheses, we might be able to measure that thing that felt so nebulous, that felt so kind of difficult to touch, but you know it when you see it. When you don't have it, you're also aware of it. So back to Stella, and I would like to end on this note with Stella. I think, in hindsight, what we learned, my colleague Kathy Green and I really appreciated the humanness of Stella in that moment when we were faced with the pushback and the disengagement. It's entirely possible that on that day she was sleep deprived, she was frustrated because perhaps she had asked for certain things from her supervisor, hadn't gotten it because the supervisor didn't visit that often. Maybe she was distracted, maybe she was suspicious of people like us who were coming with an improvement method she had never heard about. She had other ways of doing improvement. What we were describing was foreign to her, so she was suspicious of us. And so I think remembering the humanness in all of us as we work in co-production is really important. And I just wanted to end with the 3 lessons. The first one's around curiosity, nurturing our curiosity, finding ways to stay curious, even when we think we know. Just pause for a few seconds, sit on your hands, do whatever tips or tricks you may have to just listen a little bit more before you make any conclusions. And then, of course, when we learn, we should act on the thing we learn. It's a waste of human ingenuity. It's a waste of people's time and effort when they share with you and then you don't act on it. And then, of course, as we act, let's make sure we're learning. In case our original idea didn't work or the original thing we thought would work didn't work, let's learn, let's adapt, let's keep going. And then let's stay open to the things that are hard to measure but might be really important. And then, this African proverb, which is often attributed to Nelson Mandela, but it might be more anonymous. If you want to go fast, go alone. If you want to go far, go together in co-production with patients, with staff, and with communities that we serve. Thank you so much, everyone.